All right. Hi, everyone. I'm Billy Mallon. I'm a professor of clinical emergency medicine at Stony Brook, where we are waiting around in the COVID epidemic with lots and lots of cases. But I'm here today to do some of the abstracts for you. And this section is Sepsis Hot Off the Press, 2019. I got 14 papers here, which are 13 of them are from 2019 and one's from 2018. So this is the latest of the latest. Obviously, sepsis is a big topic. You can't go back through the years and years of this. But we figured that our audience, who are practicing emergency physicians, would like to know what the latest is, what's coming down the press, what's there. And so we're going to talk about that. This is an area that gives emergency physicians a bit of angst. Many of you work and you have a quote-unquote sepsis Nazi. We have a sepsis alert team with our hospital at Stony Brook as well, where a nurse will come by and say, did you meet all of the sepsis guidelines so that your hospital, will get paid and you'll meet all your benchmarks. And for a lot of emergency physicians, they're frustrated by these rules regarding sepsis for a couple of reasons. The first reason is there's no waggling in these guidelines in terms of calling something sepsis about diagnostic doubt. And we know that a lot of patients who we think have sepsis in the end don't have it. There's a paper in the database, for example, where they looked at all of the people admitted to the ICU, granted a selected population, and then at the end they looked at what their final diagnosis was, and a quarter of them were not sepsis. They were things like autoimmune disorders that were ramped up. They were things like endocrine disorders like Addisonian crisis or thyrotoxicosis. There were a whole host of other things, some vascular conditions that masqueraded as sepsis. So there's really no room in here. If it could be sepsis, you kind of got to call it out. That's one area of frustration for emergency physicians, that we're being asked to be perfect about this. And that one doesn't bother me as much. Just call it sepsis and the stuff will work out later. But the part that's really frustrating clinicians and making them unhappy is the treatment stuff that goes with this, right? You're required to give 30 cc's per kilo of crystalloid. And you're faced sometimes with patients where you really feel that's not in their best interest. People who are dialysis dependent with chronic renal failure, who are anuric. People with congestive heart failure or worse, acute pulmonary edema, where you're worried that fluid overload is going to be a problem. Or people with venous stasis with obvious signs of fluid overload. These types of patients where you have to give 30 cc's per kilo, a lot of emergency physicians are having angst about this, and it's causing clinical frustration because of their loss of control of their treatment area, their cynicism regarding overmanagement. It's making them distrust and hate regulation, and it sort of decreases their ultimate workplace satisfaction because they feel like their judgment is being disrespected. And I agree with all of that. And so when we look at any changes that are coming down the road to the sepsis guidelines, we want to make sure that we have a voice in them and that we're heard about this. Having noted all of that, I would say this regarding fluids. When we look at even elderly patients in their 70s, 80s, and 90s in terms of, how do they do with 30 cc's per kilo, prior to the sepsis guidelines, a lot of them were under volume resuscitated. So by and large, the guidelines mean to do well. They want you to give more fluids because we had about a decade of evidence that we under resuscitated these patients. Now, are there a few where it probably shouldn't be done? No question about it. You're seeing someone who's, obviously fluid overloaded with acute pulmonary edema, or someone who's, fluid overloaded who missed dialysis. What are you going to do? And I think most of us are doing the right thing, which is accepting those fallouts for when they occur. So with that as a preamble, let's jump into the papers from, by and large, mostly 2019, and see what's new on the sepsis guidelines. Many of you might remember the first topic I'm going to get into is the vitamin C thing. And, there was this paper that came out where this vitamin C protocol with high-dose vitamin C was like a magic bullet. And it seemed too good to be true. And in that sort of primer paper done by a single study physician, it was like a magic bullet with decreased mortality, decreased multi-organ dysfunction, decreasing ARDS. And everyone who saw that paper was like, wow, this is unbelievable. And it was so unbelievable that they said it has to be repeated. We need more studies, larger studies, to show that this result could be repeated. And that's the first paper we have. It's the first RCT, randomized controlled trial of this topic, 7 centers, the Citrus Ali trial. It's a little more rigorous, but still not that big, had 167 patients in it. And technically the paper was negative, but it is not going to quell this issue of vitamin C. And let me tell you why. So when they looked at IV vitamin C, 50 milligrams per kilogram, the high dose thing, versus placebo in these 167 patients, their primary outcomes were all no difference. There was no difference in their modified SOFA score, no difference in their thrombomodulin levels, no difference in their C-reactive proteins. And those were the primary outcomes. And so the study, ergo, is negative. But the secondary outcomes are still of interest to us. And the secondary outcomes were mortality at 28 days. Many of you think mortality should have been a primary outcome. But mortality at 28 days was 30% in the IV vitamin C group versus 46% in the no IV vitamin C. There was also noted to be ICU day decrease and vent day decrease in the vitamin C group. So in this particular case, the secondary outcomes might seem more important than the primary outcomes. And because the primary outcomes was negative, technically you've got to say that this is a negative paper. So it doesn't decrease the need for further study, though. And, you know, you might say had they had the balls to go for mortality as the primary outcome, they would have been the heroes of the day, and this would have been getting a lot more attention. Second paper in this series of papers on sepsis that are new is what is the Andromeda shock study? This is a study that's with my colleagues down in Chile. Many of you know I've done, 25 years of work developing emergency medicine in Chile with my colleagues down there. And this is a Santiago, Chile, multi-center study of 28 ICUs where they asked the questions, can this subjective cap refill assessment of adequate resuscitation substitute for the secondary lactate? Now, the second lactate. As you know, with the sepsis guidelines, you got to get a first lactate, and then you need a follow-up lactate. And many of the fallouts in a lot of institutions is failure to get the second lactate. So that's a little bit of a bummer. Now, at Stony Brook, we solve that by when you order the first one, you're already ordering the second one if it's a sepsis patient, so that it's already going to get done whether you think about it or not. But these authors asked the question that if you're talking about a resuscitation target, can we look at their capillary refill as a subjective sign of adequate resuscitation? And you might say, this sounds crazy, the lactate's pretty easy. But in places where the laboratory tests are expensive and a substantial part of cost, in lower resource settings, the question is there some clinical substitute? And what they found in this study that was published in JAMA, that indeed, that as a resuscitation target, they found using cap refill produced no differences in mortality, no change, that you could use this as a surrogate for multiple lactates. Now, in our system, that's not going to work because the lactate's built into the sepsis protocols and requirements. But there you have it. I think it's worth noting that some people are looking at this sepsis lactate thing and saying, do I really need multiple lactates and trace lactates? And here they looked at a simple clinical alternative and found it worked. Let's go on to abstract 3, which goes to another hot topic in the sepsis world, which is procalcitonin testing. What's been offered to us thus far in the procalcitonin gang is the positive gang, the people who love it, are one, the pediatricians like it because they think it'll help you find the bacterial infections among a peds group that is a little more difficult to assess. The second role that it's been offered up for us as is if the procalcitonin is low, that maybe it's not a bacterial infection and you could stop IV antibiotics sooner in an adult population that's in an ICU. And so, here we have this abstract from in Chest in 2019 by Pepper et al. That did a meta-analysis of all randomized control trials of procalcitonin testing versus no procalcitonin testing. They had 16 studies, 5,000 patients, more than enough to sort of wrap your head around in terms of the numbers. And overall, they found a slight decrease in mortality when procalcitonin was used. But in the studies that had higher adherence to the protocols and those where they used procalcitonin alone, i.e. they didn't have the CRP to cheat with, there was no mortality benefit found. So if you look at the bias potential in the studies, in the more neutral studies, it didn't seem to work. How much did it decrease antibiotics use? Was it, tons of change in how long they were on IV antibiotics in this? No, it was 1.3 days. What was the conclusion of the authors of this meta-analysis? Is that better studies, better design still needed to really flesh out the role of procalcitonin testing. Now, in the peds world, I think this is sort of already out the barn, and there are lots of peds protocols looking for bacterial illness in small children. And so I don't think the procalcitonin is going away. But if you believed that this is really going to decrease the length of IV antibiotics by getting it in the emergency room and allowing it to be followed, that was really not found here. Next topic in the steroid world. It seems like the topics keep coming around and doing the same thing. Have we not looked at steroids enough in sepsis? Well, we're still wrangling with it. We're still wrangling whether it works, what dose, should you be using it, should it be physiologic doses, should it be supraphysiologic doses, and this has been going on for years and years. But we have some recent abstracts, and in this chapter, abstracts 4, 5, and 6 continue to look at this. And I would just say, if you wanted the punchline, they continue to give sort of mixed results. And while the sepsis theory, the theory is that while you're under the stress of this sepsis condition, that you might need stress doses of adrenal corticoids to help support you, sounds really, really logical. It just hasn't borne out in a convincing way. So let's look over these 3 papers and see where they're at. And it's 3 different new meta-analyses. They're all meta-analyses. 4 is a meta-analysis of 19 studies with over 7,000 patients. The strength here is they're all placebo-controlled. They're all sicker patients with severe sepsis or septic shock. And they found a 2.7% decrease in mortality, 9% relative, at 28 days. And, that's a razor-thin benefit. If it was really important, you'd think that you'd find more than that in this huge cohort. Abstract 5 is a less selective meta-analysis with 30-something trials and almost 10,000 patients. And they also found a 2.9% decrease in mortality at 28 days. They found a 2-day decrease in pressor requirements, a 1-day decrease in ICU days, a 1-day decrease in the duration of shock vital signs. But they also found that the steroids came with a little bit of a price, and it's going to be no surprising to you what it is if you're giving people decent doses of steroids. There was more hyperglycemia and more hypernatremia, and benefits overall were unclear. But now, so that's 4 and 5, both found small differences, 2.7% decrease in mortality in one, 2.9% difference in the other, with these large meta-analyses. And 6 is finally, the last of these meta-analysis, found only a decrease in ICU days. And that's probably the softest of outcomes, because when you leave the ICU, depends a lot on who rounded, when they rounded, what the other bed availabilities were. And so they found a 6% relative decrease in mortality at 28 days, but lots of questions remain with regards to steroids. There was no simultaneous look in any of these meta-analyses and on the usage of steroids with balanced solutions where there might be less sodium load. There was no consistent attempt across these meta-analyses to identify those patients that might have evidence of adrenal insufficiency. There was not much in the way of random cortisol testing. And further, there was not, as you might not expect with a large meta-analysis, there was no breakdown on really types of sepsis, subgroups, what they had, etc. And so to me, I think most people would read this as, sure, go ahead and give steroids for sepsis, but don't expect it to be a huge game changer. And probably the sicker cohorts would be the most likely group to yield benefit. And so there you have sepsis, what happened in 2018 and 2019 with regards to that. Next on the docket, low-dose pressors earlier on. A lot of people have said after you've given your 30 per kilo or maybe even a little more than that and the patient remains with a MAP that's unsatisfactory or hovering around 65, maybe at that point you shouldn't wait any longer. This isn't a disease that's going to get better tomorrow or in the next hours, and so maybe they should get some pressure support with low-dose steroids. And so we had one paper in 2019 out of Thailand. This is abstract number 7. It's a non-blinded, randomized controlled trial, 300 plus patients. And 300, it doesn't sound like that big, but these are hard studies to do and recruit for. But I would just point out that had this study had maybe 450 in it, it might have reached significance because in terms of the mortality outcome, it was 15% in the group that got low-dose pressors early versus 22% in the group that didn't, with a p-value of 0.15. And so a little larger number probably would have got that there. There was no mention in this trial, as there often is in these, and what the patient's pH was. I only mention it because pressors don't work well at pHs below 7.2. And so, there was no attempt to correct or identify that. There were also lots of secondary outcomes in this paper that were better. Decreased acute pulmonary edema, decreased time in shock by about 6 hours, decreased arrhythmias. You might think the arrhythmias would increase with this, but no, they were decreased. And so if you were talking to a group of ICU docs, and I work with Scott Weingart and Brian Wright and others at Stony Brook who lead our critical care side, and they're all really ardent believers in early low-dose pressors, that when the MAP is low, we know that there's a price to pay for that down the road, and that if they've had the fluids they should have and the MAP isn't responding the way you want, that they ought to get a touch of pressor, whether it's norepinepi at 1 or 2 via a drip. That would help. So take that for what you want. This data is not particularly compelling, but I think if there was a critical care group of docs here, they would be pretty sold, not just on this study, but on other data around it. Now, as I mentioned, the paper's from Thailand, and there might have been weird causes of sepsis in there, like things like strongyloides and TB and things like that. But that's, neither here nor there, just to say that it's a different group of diseases when you're talking about Southeast Asia. Next question is fluids and how much. We know that we're supposed to give 30 cc's per kilo, just as an entry thing. And last year in the emergency medical abstracts, we did a whole big breakdown of the balanced solutions versus the normal saline. And certainly up front, I don't think it matters. What your first liter is, it doesn't matter. But once you get to 40, 50, 60 cc's per kilo, there's a problem with normal saline, which is, as they will all tell you, it's not normal, it's too much salt. And that there are consequences to that. The first thing you start seeing is a hyperchloremic acidosis, and it's possible that the sodium chloride loads are causing adverse kidney outcomes. And so you want to protect your patients from that by going to balanced solutions. And so we got a couple papers here that look at this from 2019. Abstract 8 is the RIFS paper, which is restrictive IV fluids. It's a randomized pilot non-blinded study rather. And this study I just think is just kind of amusing in the picture that we're at, where if you just said sort of our baseline is they need more fluids, 30 cc's per kilo plus, that balanced solutions are better, particularly as you get to the higher amounts of fluids. Here you have a paper that looks at restrictive IV fluids, and they compare less than 60 cc's per kilo in the first 72 hours versus, say, what happened in Rivers, which is 160 cc's per kilo in the first 3 hours, at 2 hospitals. And 30-day mortality was the primary outcome, and there was no difference in that mortality with this more restrictive strategy, and no change in ICU days, multi-organ dysfunction, etc. Abstract 9, hypertonic saline and sepsis. If I just said that the salt loads are the problem, then obviously we shouldn't be studying hypertonic saline here. We should be going to balanced solutions. This is a Belgium systematic review of 8 trials with just under 400 patients in it, so still not huge. And they found that in that review, there was no signal that this salt load caused problems. There were no renal problems. There was no mortality change. The overall volumes were smaller. And so these kinds of papers, I just pull them out just because they happened in the most recent literature as just the question about which fluids and how much and how to do this. I think right now it's leaning more towards balanced solutions, particularly as you go further up, and lactated ringers seems to be the most convenient of them. But there are still people looking at smaller, more restrictive fluid strategies and hypertonic saline strategies. And that leads us probably to the most important of the 3, which is the SMART trial reanalysis done at Vanderbilt. And the initial SMART trial found, when they looked at mortality of balanced solutions versus non, found 10.3% mortality in the balanced solutions, with 11.1% in the non-balanced solutions, basically normal saline, and that had a p-value of 0.008. In other words, it didn't reach the 0.05 threshold, and so it missed it by that much, as Get Smart would say, and so it was not significant. But a lot of the people who are familiar with the details of the data said, not so fast, Buffalo Breath. We're going to look at this stuff again, and just to be clear about it, it was a pre-planned secondary analysis of the SMART data. And who did they want to look at specifically? They wanted to look at the 1,600 ICU admits, and in that group, where they looked at balanced versus non, mortality was 26% versus 31%, and the p-value was 0.01. There was less major adverse kidney effects and less needs for dialysis, and so the smart people in the end cried, yes, balanced solutions have won. And that's probably a paper you're going to hear a lot more about from your critical care people, who all were aware that the original SMART trial published that p-value that was not significant. And here you find, when they did the reanalysis of the sicker group, it was in fact significant, that balanced solutions did better. Lactated ringer, plasma-lyte did better than normal saline. All right. I think the balanced solution thing is where we're all going. But again, I just want to say, just kind of as, an old fuddy-duddy who's, slow to change maybe, that, for the first liter, if you told me all I could have for the first liter of anyone's resuscitation was normal saline, I'd actually be pretty much okay with that. I don't need a big menu of balanced solutions. But, lactated ringers is widely available. It is more expensive. It is harder to store than normal saline. All right, abstract 11 in this group, goal-directed therapy. As we know, early goal-directed therapy was offered up. And in 2019, this is the first long-term follow-up of goal-directed therapy. So they took the people who were in the earlier studies and they said, now a year, 18 months has gone by. Let's see whether there was any long-term effects from having sepsis managed with early goal-directed therapy. Were there any long-term? Were there any sustained benefits from this strategy? And I think my instincts are, just hearing the question, that it would be unlikely. I mean, the real thing is to survive your sepsis, get out, rehab, get back to as normal as you can. I personally wouldn't expect what your resuscitation looked like to have a big long-term outcome, but certainly it's a valid question to ask and look at it. What they found was that 95% of the patients were available for follow-up at 90 days, 6 months, and 12 months, and there were no differences on quality of life based on what type of resuscitation you got. Both groups had decreased quality of life versus non-sepsis controls. In other words, when you get sepsis and you're in the ICU and you're sick and you get beat up, you don't return to your baseline. You have some ongoing, time to recover, and that this is a significant hit. And we know this from anyone who's been in an ICU for a week, that they have muscle atrophy, respiratory, all kinds of complications that take a long time to recover from. And indeed, they found that, this is a bad thing to have happen to you. And early goal-directed therapy improved neither quality of life nor mortality at 6 and 12 months. And so this doesn't mean that early goal-directed therapy isn't useless, because we're really more interested in the mortality from the primary event, renal failure, other things in the primary event. But here, if you looked at the first long-term outcomes of early goal-directed therapy, it turned out to be not that much. There was no yield here, and that's kind of unfortunate. I'd like to hear that they were really easy to get better and that they had some, downstream effects of this. But alas, no, at least in abstract 11. And finally, that takes us to some quality markers, bundles, CMS compliance stuff, the stuff that makes all your heads explode. And the title of abstract 12 says it all. High quality evidence is lacking for SEP1, the sepsis 1, right? Antibiotics less than 3 hours, 30 per kilo, the repeat lactate in less than 6 hours. These are all the things we're living with. And what they did here, it's a meta-analysis, 17 studies, 6,000 patients, observational. They found no change in survival with early versus late antibiotics, but we believe that early appropriate antibiotics matter. They didn't find it here. No change in survival with fluids that exceeded the 30 cc per kilo kind of thing. All right, maybe some of them didn't need it. No change in outcomes with lactate chasing. And so this is saying that if we're going to create these, binding quality markers that are going to change all of our practice, you would like to think there would be high quality evidence behind them. And what this paper says is, all right, we get it, you mean well, but there's really no evidence that we needed to rearrange our whole system for this. Having noted that, most of us have heard the information that mortality has gone down, early antibiotics matter, every 15 minutes in delay in antibiotics matter, and so I don't know as if this trumps all that other data that's out there. Abstract 15 looks at what could be down the road, the 1-hour sepsis bundle. I need that like I need a gunshot wound in the head. A logical ER, many ERs are going to have these people spend 15, 20, 30 minutes in triage, waiting for an appropriate care site to be identified to put them into. So if I'm only given an hour, I just wasted 33% of my time getting them into the room. And so the quick answer to this is it's really not feasible. There are lots of factors that these authors identified that account for delays, even at Mass General. The authors indicate that this would require a complete reorganization of emergency department triage and processes of care, including how pharmacy delivers medications and fluids and things to be used, and that really we've probably squeezed this orange for the benefit that we're going to find, and that trying to get to the 1-hour bundle, it's not going to be feasible. Lots of things are going to fall out, and there's certainly, if there's no evidence, no high-quality evidence for the current bundle, then there won't be any for this either. And 14, another great paper, final SEP1 core measure, 7 different hospitals that are all respected academic centers. How did they do? 2/3 of the patients failed, 67% failed SEP1. Omission of the second lactate, as I noted earlier, was common. Only 15% of the patients got antibiotics in less than 3 hours. And the conclusion of these authors is, and I think it's a valid one, is that the current SEP1 bundle that we're all under does not differentiate between high and low quality care, and that there's a fair amount of just hoop jumping in here, maybe just for the sake of hoop jumping. And so that's the zinger here, but we need to be aware of this so that we can be prepared to defeat them when they want to go to the 1-hour bundle, which I just think is crazy talk. The 1-hour bundle is crazy talk. And I always remember there was a great paper on meningitis where they asked infectious disease specialists how fast they thought antibiotics should go up in meningitis. And they all said under 30 minutes. What they didn't know is they looked at cases that they had managed and saw how fast they actually got the antibiotics up, and it was hours. Hours. So it's easy to say 30 minutes. It's just not easy to do. It's easy to say an hour. It's just not easy to do, particularly if you want it to be 100%. And so I think we've squeezed the juice from the sepsis orange. We know that we need to give more fluids. We need to give early and appropriate antibiotics. We need to look at targets for resuscitation. Sure, we might need to go with low-dose pressors and things like that if the map is inadequate. But I don't think there's a lot of room for improving this by shortening those time frames. So, in summary, key points and recommendations. Sepsis therapy is evolving and mortality rates remain high, although they've improved. Lots of therapies have been tried and shown to be of no measurable benefit. And in terms of the vitamin C and the metabolic bundle, we need to see more data on that, if you will. Cap refill seems to be an adequate marker for sepsis resuscitation. It's as good as lactate, but I don't see us getting away from the lactate since we have to be able to do it. Corticosteroids for sepsis may be beneficial with regards to mortality, ICU, and ventilator days, but it's still a messy topic and controversy rages on. Balanced crystalloid solutions like lactated ringers were beneficial in sepsis patients in one massive but non-blinded trial, comparing them to normal saline, the SMART trial. We talked about that with the pre-planned secondary outcome analysis. Early shock control with norepi is being explored, and in some early trials, there's suggested a possible mortality benefit. Restrictive IV fluid strategies in sepsis have been of great interest to researchers, but I don't see, it's of interest only, not something to do in practice right now. Long-term follow-up from the ARISE trial found that early goal-directed therapy did not improve their overall long-term results and quality of life. And the SEP1 performance measure bundles from CMS are lacking in reliable evidence base and may not be feasible to implement. When they want to go to a 1-hour thing, I think we need to fight that off as a specialty, and hopefully ASEP and AAEM and others will represent our needs there, because I just don't think there's more juice in that orange to get. Thank you very much. That's your sepsis update for 2019, hot off the press, 14 papers, all from the newest in the literature. Bye-bye.